Imagine for a second that you are the commander of a vast, sprawling army. You have this incredible advantage over your enemy: speed. Your troops can mobilize, they can replicate, and they can advance faster than anyone else on the battlefield.
It sounds unbeatable.
It sounds unbeatable, right? I mean, in a conventional war, speed is.
Yeah.
It's usually the deciding factor.
It is. Speed almost always wins. But here's the paradox, and it's the hook for everything we're going to discuss today. That speed, that relentless drive to move forward and multiply.
Yeah.
That is exactly the thing that gets you killed, because if you're running faster than everyone else, you are the first one to trip over the wire. You're the first one to run headfirst into the trap.
And that, right there, is the fundamental logic of cytotoxic chemotherapy. Today on the Deep Dive, we are tackling Pharma 66. We are looking at cytotoxic drugs. And the subtitle for today really should be When Division Becomes the Weakness.
It's a fascinating and, frankly, brutal topic. We're pulling this primarily from two of the heavy hitters in the pharmacology world. We've got Goodman and Gilman's The Pharmacological Basis of Therapeutics, specifically their section on cytotoxic drugs, which gives us that deep molecular mechanistic view.
The Bible of pharmacology.
Exactly. And we're pairing that with Katzung's Basic and Clinical Pharmacology, their chapter on cancer chemotherapy, which really provides the clinical scaffolding. How do we actually use these things in the real world in a hospital?
And our mission for this deep dive is to synthesize them. We aren't just going to list off drug names. That's boring, and honestly, you could look that up anywhere. We want to understand the logic of cytotoxicity.
Yeah.
We want to get at how we aren't just, bombing a cell. We're actively sabotaging its internal machinery.
Right. And just before we dive in, let's be really clear about our approach. This is an interpretive synthesis. We want to give you the mental framework, those aha moments that connect the dots, but we are not a substitute for the text.
Absolutely not.
Use this conversation as your map, but you still need to walk the territory yourself. Go back and read those chapters.
Okay, so to start, let's lay out the key takeaways. By the end of this hour, what are the big ideas our listeners should have locked in their brains?
I think there are 5 pillars here. First, growth is vulnerability. Why does this simple act of a cell dividing create a therapeutic window for us? Second, phase specificity. The difference between a sniper rifle that hits a very specific phase of the cell cycle and a bomb that just hits anywhere.
Okay, a sniper versus a bomb. I like that. What's number 3?
Dose-limiting toxicities. We really need to understand why the bone marrow, the gut, and hair follicles take such a beating, and why that, unfortunately, limits how much drug we can safely give.
The price of admission.
The price of admission. Fourth is resistance. How does the enemy learn to fight back? And finally, supportive strategy. We aren't just throwing poison and walking away. We have to manage the fallout with things like antiemetics and growth factors. It's an entire package.
Great. So let's define the enemy first. If you look at Katzung, cancer is defined by a defect in the control mechanisms that govern cell survival, proliferation, and differentiation.
Basically, the stop signs are all broken, and the gas pedal is stuck to the floor. But it's actually more than just uncontrolled growth. There's this concept of the tumor stem cell that Katzung highlights.
Right.
It's a very small subpopulation of cells within the tumor that retains this unique ability to undergo repeated cycles of division and, crucially, to migrate, to metastasize.
So even if you kill 99.9% of the tumor, if you miss those few stem cells, the factory is still open for business.
Precisely. The factory will just rebuild itself. And adding to that difficulty is something called genetic instability. These cells are just sloppy copiers. They make a ton of mistakes when they duplicate their DNA.
Which you'd think would be a bad thing for them.
Usually it is bad for a cell, but for cancer, it's a feature, not a bug. It allows the tumor to evolve resistance incredibly quickly. They're shapeshifters.
So we have a shape-shifting enemy that doesn't know how to stop growing. And today we're going to look at how we turn that very growth against them. We've got, 4 main areas to cover?
I think so. The rules of engagement, which is really the math of killing cells, then the heavy artillery, the alkylating agents, then the sabotage, the antimetabolites, and finally the counterattack, how the cancer fights back against us.
Perfect. Let's start with the rules of engagement. Because before you can even think about prescribing a drug, you have to understand the kinetics of how it actually kills.
This is where we get into something called the log kill hypothesis. This comes out of a model called the L1210 model, a mouse leukemia model.
Unpack this for us. What is the cardinal rule of chemotherapy?
The cardinal rule is that there is an inverse relationship between the number of cancer cells and the probability of a cure. Fewer cells, better chance. But the log kill hypothesis states something very, very specific. Cytotoxic drugs kill a constant fraction of cells, not a constant number.
Okay, let's visualize this because this is where the math can get a little dizzying, but it's so important. If I have a bacterial infection and I take an antibiotic, I usually expect a fairly linear wipeout. But cancer's different. If I have, say, a billion cancer cells, that's 10 to the ninth power, and I give a drug that kills 99.9% of them.
Which is what we call a 3-log kill. You're knocking 3 zeros off the end of that number.
Right, so if I kill 99.9% of a billion, I haven't won the war. Not even close. I still have a million cells left. 10 to the sixth.
Exactly. You haven't wiped them out. You've just, thinned the herd. And if you treat again with that exact same dose, you don't kill the remaining million plus some extra. You kill 99.9% of that million.
Leaving me with 1,000 cells.
Leaving you with 1,000. You have to keep hitting them cycle after cycle to drive that number down theoretically to 0. This is why chemotherapy is given in cycles with breaks in between.
You can't just give one massive dose and go home.
No, because the toxicity would kill the patient long before you got every single cancer cell. It's a war of attrition. You have to chip away at the logs.
This also explains something that I think a lot of people wonder about: adjuvant chemotherapy. Patient has a tumor, a surgeon goes in and cuts it out. The surgeon comes out and says, I got it all, the margins are clean. But then the oncologist says, okay, now we need to do 6 months of chemo. Why?
It's because of that log kill math. The surgery removed the visible tumor, the bulk disease. Maybe you got it down from 10 to the 10th cells to maybe only 10 to the second. But what if there are microscopic deposits, micrometastases floating around in the bloodstream or lymph nodes?
100 cells or 1,000 cells you can't see.
Right. You need the chemotherapy to mop up that remaining fraction.
Right.
If you don't, one of those cells will eventually land somewhere, start dividing, and the whole thing grows back.
Now, that L1210 model that was done in mice with leukemia, right? A liquid tumor.
Yes, liquid tumors in mice, which grow exponentially. Very predictable.
But humans aren't mice. And a solid tumor in someone's lung isn't the same as liquid leukemia. So how does the math change when we talk about real human solid tumors?
That is where we move from that nice, clean, exponential growth model to something called Gompertzian growth.
Gompertzian. It sounds like a sci-fi villain.
It does, but it's actually a much more accurate description of reality. In that mouse leukemia model, the cells just grow exponentially forever until the mouse dies. It's a straight line going up on a log scale. But in a human solid tumor, growth isn't constant.
Is that because they just run out of room? Or nutrients?
Both. Room, nutrients, and most importantly, blood supply. The Gompertzian curve shows that the growth fraction, the percentage of cells that are actually actively dividing at any one time, is highest when the tumor is small. Maybe about 1/3 of its maximum possible size.
Okay, so a small tumor is growing really, really fast.
Fast and furiously, but as it gets massive, the growth actually slows down. The center of the tumor might even become necrotic, just dead tissue, because the blood vessels can't penetrate that deep. The cells on the inside go into a resting state. We call that the G0 phase.
And here is the aha moment for me. Chemotherapy targets dividing cells.
Bingo! This is one of the great ironies of oncology. You look at a huge mass on a CT scan and you think, wow, we need to hit this with everything we've got. But the drugs we use depend on cell division. If the cells are just sitting there resting in G0, the drugs will just bounce right off them.
So a massive tumor, which has a lot of resting cells, is actually harder to kill with chemotherapy than a small one where almost every cell is dividing.
Exactly. Large tumors have low growth fractions. Small tumors, or those tiny micrometastases we were talking about, have very high growth fractions. They are much more sensitive to the drugs.
This completely reframes why debulking surgery works. I always wondered about that. If you can't remove the whole cancer, why bother cutting out half of it? It's not just to make the patient feel better.
No, it's a deeply strategic move. By removing the bulk of the tumor, you remove the crowding and the nutrient limitation. You essentially force the remaining cells out of that G0 resting phase. They sense the new space, the new resources, and they start dividing rapidly again to fill the gap. We call this recruitment.
You're kicking the hornet's nest.
You kick the nest, they all swarm out, and that is when you hit them with the chemo. You are actively making them vulnerable by forcing them to grow. It's a way of manipulating the cell cycle to your advantage.
That is absolutely fascinating. So speaking of the cell cycle, we should probably quickly map out the terrain. We have G1S, G2M.
Right. The easiest way to think of it is as a factory assembly line. G1 is the prep phase, gathering materials, checking the blueprints. S phase is synthesis. That's when the DNA is actually copied. And this is a critical point of vulnerability.
Okay.
G2 is the final check, making sure the copies are good before splitting. M is mitosis, the actual physical division of the cell into two daughter cells. And then, of course, there's G0, the resting phase, off to the side.
And we classify our weapons based on this map, right?
We do. We have CCS cell cycle-specific agents. These are our snipers. They only work if the cell is in a specific phase, like S phase or M phase. These are fantastic for high-growth tumors where almost every cell is on that assembly line.
And then we have the opposite, CCNS cell cycle nonspecific.
These are the heavy bombers. They can kill a cell whether it's actively cycling or just resting in G0, though they still tend to work a bit better if the cell is active. These are much more useful for those large, slow-growing tumors we talked about.
Okay, let's open up the armory then. Section 2, the heavy artillery. We're talking about alkylating agents and the platinum analogs.
This is the oldest class of cancer drugs we have, and the origin story is, well, it's dark. It's really a story of turning a weapon of war into a medicine.
This goes back to World War I.
It does. Goodman and Gilman gives us the full history here. In WWI, soldiers who were exposed to sulfur mustard gas suffered these horrific chemical burns. But attending physicians noticed something else, something systemic. These soldiers had profound lymphoid aplasia. Their bone marrow was completely wiped out.
Their white blood cell counts just plummeted.
They plummeted. So in the middle of all this horror, someone had the insight to think, wait a minute. If this gas wipes out normal white blood cells, maybe it could wipe out cancerous white blood cells.
It's an incredible leap of logic.
It is, and it was actually Louis Goodman and Alfred Gilman themselves, the authors of the textbook we're referencing, who did the first clinical studies in 1942. They used a modified version called nitrogen mustard on patients with lymphoma, and the tumors melted away. It was, for all intents and purposes, the birth of modern chemotherapy.
So how does it actually work? How does mustard gas, or its medical cousin, kill a cancer cell?
It's essentially a chemical handcuff. These drugs are highly reactive. Chemically, they form these things called carbonium ion intermediates that are positively charged and just desperately want to latch onto something electron-rich.
And the most electron-rich target in the cell is the DNA.
It's the juiciest target by far, specifically the N7 position of the guanine base.
The N7 of guanine, that's the bullseye.
That's the spot. So the drug binds to that guanine. But here is the really key part. Most of these agents are bifunctional. They have two grabbing arms. So one arm grabs a guanine on one strand of the DNA, and the other arm reaches across and grabs another guanine on the opposite strand.
They cross-link the DNA.
They cross-link it, yeah.
The zipper metaphor you used earlier is really good here.
It's perfect. DNA has to unzip to be replicated or transcribed. Imagine you take a welder and you fuse two of the teeth on a zipper together. When the cell's machinery tries to unzip that DNA to copy it, it gets stuck.
Or if it pulls too hard, the whole thing just rips apart.
Strand breakage, exactly. The cell has systems to detect this massive damage. It tries to repair it, but the damage is too catastrophic. So it triggers apoptosis programmed cell suicide. It essentially realizes, I am too broken to continue living, and initiates a self-destruct sequence.
Now, in this category, we also have the platinum drugs. Cisplatin, carboplatin, oxaliplatin. Chemically, they aren't technically alkylating agents, right?
Yes, that's correct. They form metal adduct, not carbon bonds. They're inorganic metal complexes, but functionally, they do the exact same thing. They get in there and create covalent crosslinks in the DNA, jamming the zipper. So for all clinical purposes, we group them together.
Let's talk about some of the specific agents, because they each have their own quirks. Let's start with cyclophosphamide.
Cyclophosphamide is a classic. It's a Trojan horse. When you inject it into a patient, it's completely inactive. It's harmless. It has to take a trip to the liver first. The cytochrome P450 enzymes in the liver have to metabolize it and activate it.
But there's a catch. There's always a trade-off.
Always. When the liver activates it, it produces the active cancer-killing drug, but it also produces a toxic byproduct called acrolein.
And acrolein is nasty stuff.
It is extremely irritating to epithelial tissue. It gets concentrated in the urine, and it accumulates in the bladder. It can cause a severe condition called hemorrhagic cystitis. Basically, chemical burns inside the bladder wall that lead to significant bleeding.
Which is why there's a specific management strategy for it.
Absolutely. Patients on high-dose cyclophosphamide need aggressive IV hydration to flush the bladder, and sometimes a protector drug called Mesna. Mesna concentrates in the bladder, finds the acrolein, binds to it, and neutralizes it. It's the antidote to the side effect.
Fascinating. Okay, then we have the nitrosoureas like BCNU or carmustine. What's their special power?
Their superpower is that they are highly lipophilic. They dissolve in fat. And what that means, practically, is that they can cross the blood-brain barrier.
Which most chemo drugs can't do.
Most can't. The blood-brain barrier is an incredibly effective filter. But if you have a brain tumor, like a glioblastoma, you need a weapon that can actually get to the battlefield. These are your go-to agents for that.
What about a drug like Bosylphan?
Bosylphan is interesting because it's almost too good at what it does. It is incredibly selective for the bone marrow. We use it in situations where we want to completely wipe out a patient's marrow, what we call myeloablation-like, before a bone marrow transplant for CML, chronic myelogenous leukemia. It completely clears the deck.
One more before we move on. Temozolomide.
Ah, yes. A methylating agent. So it's a bit like a lighter version of the heavy alkylators. It's monofunctional. It adds one methyl group. But its advantages are huge. It spontaneously activates, it doesn't need the liver, and it also crosses the blood-brain barrier. It's become a standard of care for many brain tumors because it's just so much easier to administer and better tolerated than the old nitrosoureas.
Okay, so that's the heavy artillery, the brute force approach of physically welding the DNA shut. Now let's move to section 3. Sabotage, the antimetabolites.
This is a much more elegant, almost insidious form of warfare. If alkylating agents are a sledgehammer, antimetabolites are counterintelligence. They're spies.
I really like the metaphor of counterfeit currency here.
It fits perfectly. These drugs are designed to mimic the normal building blocks of DNA, the purines and pyrimidines, or they mimic the vitamins needed to make them, like folate. The cell is rushing to replicate its DNA during the S phase. It reaches out for a building block, it grabs the drug by mistake, and tries to incorporate it.
And then the whole system just grinds to a halt.
Exactly. It's like putting a bent coin into a vending machine. It jams the entire mechanism. Or like putting a sugar cube into a brick wall. The structural integrity is just gone.
Let's talk about the folate antagonists first. The classic here is methotrexate.
Methotrexate is a direct mimic of folic acid. Cells absolutely need a reduced form of folate to synthesize thymidylate, which is a key letter in the DNA alphabet, the T in A, T, C, G. Methotrexate works by binding to and inhibiting the enzyme DHFR dihydrofolate reductase.
So it shuts down the factory that makes the T blocks. The cell runs out of raw materials. It starves.
It starves for thymidine. No thymidine, no new DNA, no division. But methotrexate is dangerous. It's not selective. It also starves your healthy, rapidly dividing cells in the gut and the bone marrow.
Which leads to one of the most clever strategies in all of oncology, the rescue.
The leucovorin rescue. It is so cool. Leucovorin is a form of folate that doesn't need that DHFR enzyme to become active. It's already reduced. So the strategy is you give a potentially lethal dose of methotrexate to kill the tumor, and then hours later, you administer leucovorin to save the normal cells.
Now, wait a minute. Why doesn't the leucovorin just save the cancer cells, too? That seems like a massive risk.
It can, and the timing is critical. But the theory relies on differential transport. Normal cells are generally better at sucking up the leucovorin from the bloodstream and using it to recover. Cancer cells are often less efficient or are already too damaged by the methotrexate to be rescued. It's a high-stakes game of chicken. You push the patient right to the brink of lethal toxicity, and then you pull them back.
Wow. High stakes is right. Okay, what about the pyrimidine analogs? Let's talk about 5-fluorouracil, or 5-FU.
5-FU is the false brick. It looks almost exactly like uracil or thymine, but it has a highly electronegative fluorine atom stuck on it. Its main job is to inhibit an enzyme called thymidylate synthetase, or TS.
So another way of stopping the production of thymine.
A different way, yes. The cell picks up the 5-FU, the enzyme tries to process it, and that fluorine atom basically makes it get stuck. It forms a covalent bond, we call it suicide inhibition. The enzyme essentially kills itself by trying to process the fake drug.
And DNA synthesis just halts.
It halts. And there's an oral version of this, right? Capecitabine.
Right, capecitabine is a prodrug. You can swallow it as a pill, it gets absorbed, and then your body's enzymes convert it into 5-FU. It allows for much easier administration, so the patient doesn't have to be hooked up to an IV pump for days on end. Then we have drugs like cytarbine and gemcitabine.
Cytarbine, or Aracy, is a huge drug in the world of leukemia. It works by inhibiting DNA polymerase. That's the actual machine that builds the DNA chain. It gets incorporated into the growing chain and then acts as a chain terminator. It stops the elongation dead in its tracks.
And gemcitabine.
Gemcitabine is similar, a bit of a multitasker, but one of its key actions is inhibiting an enzyme called ribonucleotide reductase. The specific mechanisms vary, but the theme is always the same. Sabotage the supply line or sabotage the assembly machine, specifically during S phase.
So to bring this into the real world, let's look at that case study from Katzen. There's a 55-year-old man with colon cancer. He's had surgery, but they found positive lymph nodes, which means he's at high risk for recurrence.
Right, so surgery got the bulk disease, but we are highly suspicious of micrometastases. The standard adjuvant protocol here is FOLF-OX.
FOLF-OX. Sounds like a sci-fi battalion. Break that down for us. What is it?
It's an acronym. It stands for folinic acid, which is leucovorin, fluorosil, which is 5-FU, and oxaliplatin.
Okay, let's dissect the logic of that combination. Why those three drugs together? Why not just give a huge dose of one of them?
This is the art of combination chemotherapy. You have 5-FU, the antimetabolite, which is sabotaging the S phase. You add leucovorin, which in this specific case doesn't act as a rescue. It actually acts as a biochemical modulator. It helps the 5-FU bind more tightly to its target enzyme, the phthalate synthase.
It makes the sabotage more effective?
It tightens the knot. It makes the suicide inhibition almost permanent. And then you add the oxaliplatin.
And that's your platinum analog, the heavy artillery.
That's the heavy artillery. It's in there cross-linking the DNA. So you are hitting the cell with two completely different mechanisms. You are starving it of building materials with the 5-FU, and you are physically breaking its DNA with the oxaliplatin.
You're attacking from two flanks at once.
Exactly. And because they work through different mechanisms, they generally don't have overlapping resistance patterns, and they have different toxicity profiles. It makes it much, much harder for the tumor to survive. If it develops resistance to 5-FU, the oxaliplatin can still kill it, and vice versa.
Brilliant. Okay, moving on. Section 4. So we've welded the DNA shut, we've starved the synthesis process, but let's say a cancer cell actually manages to copy its DNA and gets ready to divide. It enters the M phase.
Mitosis, the physical act of splitting into two. To do this, the cell has to build this intricate internal scaffold, mitotic spindle, which is made of tiny protein tubes called microtubules.
And their job is to, pull the chromosomes apart?
Exactly. They polymerize, grow out, grab onto the duplicated chromosomes, and then pull them to opposite ends of the cell so it can split cleanly down the middle.
And this is where the microtubule inhibitors come in.
Yeah.
We are freezing that machinery.
Precisely. And we have two main families here, and they're like fascinating mirror images of each other. The vinca alkaloids and the taxanes.
Let's start with the vincas. Vinblastine, vincristine.
The vinca alkaloids work by preventing the assembly of that scaffold. They bind to tubulin, the individual protein building blocks of microtubules, and stop them from linking together from polymerizing.
So the construction crew shows up for work, but they can't bolt the steel beams together.
Perfect analogy. No scaffolding means no pulling apart of chromosomes. The cell gets stuck in the middle of mitosis, it can't proceed, and that triggers apoptosis.
And then we have the taxanes, paclitaxel, docetaxel.
They do the exact opposite. They promote assembly so much that they prevent disassembly.
Wait, why is that bad? Don't we want the scaffold to be built?
The scaffold needs to be incredibly dynamic. It needs to build up to grab the chromosomes, pull them apart, and then it needs to break down so the cell can finish the division process. The taxanes stabilize the microtubules so much that they become rigid, frozen rods they can't depolymerize.
Ah, so the construction crew builds the scaffold, but then they superglue all the joints and refuse to take it down. The whole site is paralyzed.
Exactly. Frozen in a state of mitotic chaos. The cell attempts to divide, fails catastrophically, and again triggers apoptosis.
And the source detail here is just great paclitaxel was originally derived from the bark of the Pacific yew tree.
Yes, Taxus brevifolia. It was part of this massive screening effort by the National Cancer Institute to test thousands of natural products for anti-cancer activity. Nature's a pretty good chemist.
Now, these two classes of drugs have very distinct toxicities, even though they both target microtubules. This is a really important clinical point.
This is a classic board exam question and a vital clinical pearl for anyone in practice. Vinblastine causes bone marrow suppression. That's the usual suspect for most chemo. But vincristine, it almost completely spares the bone marrow. Instead, its dose-limiting toxicity is neurotoxicity.
Nerve damage.
Severe peripheral neuropathy. Numbness, tingling in the fingers and toes, trouble walking, foot drop. And the reason is your neurons also rely on microtubules. They use them like railroad tracks to transport neurotransmitters and other essential components down the length of those long axons. Vincristine just completely derails those trains.
That is such a crucial clinical distinction. If you have a patient who already has nerve issues, say from diabetes, you might think twice about using vincristine.
Precisely. You have to tailor the weapon to the patient's underlying physiology. It's not one size fits all.
Okay, section 5. Natural products and antibiotics. Now, usually when I hear the word antibiotic, I think kills bacteria.
In this context, the word antibiotic just means a substance produced by a microorganism that is toxic to other cells. These were isolated from soil bacteria, mostly from the genus Streptomyces, but they are far, far too toxic to ever use for something like strep throat. They destroy mammalian cells just as easily as they destroy bacteria.
And the big guns in this category are the anthracyclines, doxorubicin.
The red devil.
Why do they call it that?
2 reasons. The liquid drug itself is a brilliant, bright red, and when you infuse it, it can turn the patient's urine red for a day or two, which can be quite alarming if you don't warn them.
In the devil part.
That would be its devilish toxicity profile.
How does it work? It seems like it has multiple ways of killing a cell.
It's a triple threat. First, it intercalates. That means it slides itself flat in between the base pairs of the DNA helix, distorting the structure. Second, and probably most importantly, it inhibits an enzyme called topoisomerase II.
Topoisomerase II. That's the enzyme that untangles the DNA knots, right?
That's the one. As the DNA helix is uncoiled to be read or copied, it gets tangled up ahead of the replication fork. Topo 2-6's job is to make a temporary double-strand cut, pass the tangled strand through the break, and then reseal it. Doxorubicin freezes the enzyme in the act after it makes the cut, but before it reseals it.
So you're left with thousands of double-strand breaks all over the genome, just chopped up DNA.
Catastrophic damage, yes. And the third mechanism is the generation of free radicals. It participates in redox cycling that creates these highly reactive oxygen species that just shred DNA, proteins, and cell membranes.
And this free radical mechanism leads us directly to its most feared specific toxicity, the heart.
Cardiotoxicity. The heart muscle, the myocardium, is uniquely vulnerable to free radical damage because it has very low levels of the protective enzymes like catalase and superoxide dismutase that are needed to neutralize them. Other organs have much better defenses. The heart just takes the full brunt of that oxidative stress.
So doxorubicin can actually cause irreversible heart failure?
Yes. And it's a cumulative, dose-dependent effect. There is a lifetime maximum dose for each patient. Once you hit that ceiling, you can never have doxorubicin or a related drug again because the risk of congestive heart failure skyrockets.
And then there's bleomycin, another natural product.
Bleomycin is another DNA shredder. It binds to DNA and generates free radicals that cause strand breaks, but it has a totally different and very unique toxicity target. It largely spares the bone marrow, which is rare for a chemo drug, but it attacks the lungs.
That causes pulmonary fibrosis?
Progressive, irreversible scarring of the lung tissue. And the reason is, again, entirely enzymatic. There's an enzyme called bleomycin hydrolase that breaks down and inactivates the drug. It's found in high concentrations everywhere in the body except the skin and the lungs, so the drug accumulates in those two tissues, causing damage.
It's just incredible how the specific side effects map perfectly to the underlying biochemistry of the organs. It's not just random bad luck.
It is not random at all. It is pure physiology. It's systems biology playing out in a very unfortunate way for the patient.
Okay. Section 6. The counterattack. We've been hitting the cancer with everything in our arsenal. But the cancer isn't just a passive target. It fights back.
Resistance. It is the single biggest challenge in oncology. You see a tumor shrink dramatically on a scan, the patient feels better, you celebrate a victory, and then 6 months later, it's back. And this time, the drugs don't work anymore.
And we break this down into primary resistance and acquired resistance.
Right. Primary resistance means the tumor was never going to respond in the first place. For example, if a tumor has lost the p53 gene, the guardian of the genome, it loses its ability to trigger apoptosis. You can damage its DNA with chemo and the cell just shrugs and keeps on dividing. It doesn't know that it's supposed to die.
And acquired resistance is when it learns to survive.
It evolves under the selection pressure of the treatment. Goodman and Gilman lays out some absolute incredible mechanisms of defiance.
Let's start with the pump.
The MDR1 gene, which codes for a protein called P-glycoprotein. Think of it as a sump pump or a bouncer at a club. The drug gets into the cell, and this pump recognizes it as a foreign toxin, grabs it and uses energy to physically throw it back out before it can do any damage. It's an efflux pump.
And the MDR stands for multi-drug resistance.
And that's the really scary part. If the cell turns on this pump to get rid of, say, a vinca alkaloid, it might accidentally also become resistant to taxanes, anthracyclines, and a whole host of other drugs. It's not specific. It pumps out anything that's bulky or hydrophobic. You can lose multiple classes of weapons all at once.
Wow. Then there's the repair crew.
Right. The cell just upregulates its DNA repair enzymes, use an alkylating agent to attach a methyl group to the DNA. The cell starts making more of an enzyme called MGMT, which finds that damage and plucks the methyl group right off. It learns to fix the damage as fast as you can cause it.
And what about the decoy?
The cell can increase its intracellular concentration of molecules like glutathione. Glutathione is a thiol, a sulfur-rich molecule. It acts like a sponge for reactive chemicals. So the alkylating agent comes into the cell looking for DNA, and the glutathione essentially throws itself in the way. Hit me instead. The drug binds to the glutathione sponge and is neutralized before it ever reaches the DNA.
It is truly sophisticated biological warfare.
It is Darwinian evolution playing out in real time inside a patient. We apply a selection pressure, and only the strongest, nastiest, most resistant cells survive to repopulate the tumor.
Which brings us perfectly to Section 7, modern warfare. We are slowly moving away from this carpet bombing of all dividing cells and towards sniping very specific signals. The era of targeted therapies.
This represents a massive philosophical shift. Instead of saying kill anything that divides, we can now say kill only the cells that have this specific mutated receptor.
Let's talk about VEGF inhibitors, a drug like bevacizumab.
Right. So tumors are metabolically hungry. They need a blood supply to grow beyond a tiny size. So they secrete a signal called VEGF, vascular endothelial growth factor, which basically tells the body to grow new blood vessels toward it. This process is called angiogenesis.
So bevacizumab is a monoclonal antibody that acts like a male interceptor.
Exactly. It's an antibody that floats around in the blood, finds that VEGF signal, and binds to it. The message never arrives at the receptor on the blood vessel cells. No new blood vessels grow. You effectively starve the tumor.
But again, the side effects are completely logical. If you stop the body from growing and repairing blood vessels,
you get wound healing complications. You can get hypertension because the blood vessels change their tone.
Mm-hmm.
You can get bleeding or clotting problems. If a patient is going to have surgery, you have to stop this drug well in advance to allow them to heal properly.
And EGFR inhibitors.
Targeting the epidermal growth factor receptor. In some cancers, like certain lung cancers, that growth switch is stuck in the on-in position because of a mutation in this receptor. These drugs, either antibodies or small molecules, are designed to specifically jam that switch and turn it off.
We had to briefly mention CAR T-cell therapy. This feels like something out of science fiction.
This is a whole different ballgame. This is immunotherapy. It's not a drug, it's a living treatment. You take a patient's own T cells out of their body. You use genetic engineering to insert a new gene that codes for a receptor, a chimeric antigen receptor, or CRR, that recognizes a specific protein on the surface of the cancer cells.
Like CD19 on leukemia cells.
Exactly. Then you grow billions of these newly engineered T cells in the lab and infuse them back into the patient.
You are literally creating a living drug, a personal army.
A living hunting drug. Tisagen-Lecluse is the big one for acute lymphoblastic leukemia. The results can be miraculous, but the side effect is terrifying. Cytokine release syndrome?
The cytokine storm.
The battle between the billions of supercharged T cells and the cancer is so violent that it releases a flood of inflammatory signals, cytokines, into the body. The patient can get raging fevers, their blood pressure can plummet. It can be fatal if it's not managed aggressively in an ICU. It requires a whole new set of skills for the oncology team.
Okay, Section 8. Let's ground this in clinical realism. We've talked about all these amazing mechanisms, but we need to talk about the human cost.
The toxicity. We talk about selectivity, but let's be brutally honest. Cytotoxic drugs are not truly selective for cancer. They are selective for cell division.
So the obvious question is, who else divides rapidly in the healthy human body?
Number one is the bone marrow. It's a factory constantly churning out red cells, white cells, platelets. That's why you get neutropenia, which leads to infection risk, thrombocytopenia, which leads to bleeding risk, and anemia, which causes fatigue. This is very often the dose-limiting toxicity, the thing that stops us from giving more drug.
Next is the gut.
The entire lining of your gastrointestinal tract, from your mouth to your anus, replaces itself every few days. Chemo kills those cells. So you get mucositis, painful sores in the mouth, and throat nausea, vomiting, and diarrhea.
And of course, hair.
Hair follicles are some of the most rapidly dividing cells in the body. So you get alopecia or hair loss.
It truly is the price of admission.
It is. And managing this is at least half the job of an oncologist and an oncology nurse. We use growth factors like GCSF to boost the marrow back up. We use powerful anti-nausea drugs. We time the cycles perfectly to allow the normal tissues just enough time to recover, but not so much time that the cancer regrows.
Which brings up this concept of dose intensity.
Right. The idea, which is supported by that log kill hypothesis, is that more is better up to a point. You want to give the highest dose possible in the shortest amount of time to kill the biggest fraction of cancer cells. But you are always, always limited by the toxicity to the patient. It's a constant tightrope walk.
You want to kill the cancer without killing the patient.
That is the grim, fundamental reality of cytotoxic chemotherapy.
So bringing it all together now for the outro, we've gone on this incredible journey from the brute force of World War I nitrogen mustards, literally welding DNA shut to the elegant sabotage of the antimetabolites and the precision freezing of the mitotic spindle.
And it's important to note that even though we have these fancy new targeted therapies and immunotherapies, these old-school cytotoxic drugs remain the absolute backbone of most cancer treatment regimens.
Why is that?
Because of that fundamental rule we started with. Cancer at its core is defined by division, and these drugs punish division indiscriminately and powerfully. As long as cancer's primary superpower is uncontrolled growth, these drugs will have a crucial place in the arsenal.
But they are very blunt instruments.
They are. We are moving from an era of carpet bombing to an era of sniping, but sometimes you still need the carpet bomb to clear the field so the snipers can do their work.
Here's a provocative thought to leave you with. We are clearly moving from an era of treating the organ lung cancer, breast cancer, to treating the molecular driver, the EGFR mutation, the ALK fusion. But will we reach a point where we can predict resistance before it even happens? Can we sequence a tumor and know its escape routes before it even tries to take them?
That is the next frontier. It's not just about hitting the target, but about anticipating the counterattack before it's even launched.
And time for our call to action. If you want the deep chemistry, the structures, the nitty-gritty of the molecular mechanisms, you have to go to Goodman and Gilman. If you want the clinical protocols, the dosing, the management of toxicities, your guide is Katzon.
Remember, the map is not the territory. We've given you the map today. Now go read the source.
Thanks for diving deep with us. We'll see you next time.